Good afternoon, everyone, and thank you for joining us for today's webinar, Best Practices for Outreaching and Managing New Enrollees for Healthcare Coverage. My name is Rachel Logan, the Training and Technical Assistance Manager at the National Center for Health and Public Housing. Here at the National Center for Health and Public Housing, we assist health center programs who serve low-income populations, specifically those with public housing primary care grant funding through HRSA. We also provide webinars such as this, monographs, and other toolkits and resources for the safety net to promote wellness in low-income communities. I would like to present a few slides of information about uninsured adults in the U.S. and those that are served at health centers. We see that about 32% of look-alike health centers served uninsured patients in 2011. About 32% of those were full health center program grantees, and in general we compare this to about 16% uninsured in the general medical care population. So health centers are more likely to serve uninsured patients. Specific to public housing primary care, which is the focus today, and you'll hear more from TCA Health about their strategies, was 33% uninsured throughout this community. So that's much higher than other health centers and much higher than the national averages. Who exactly is considered uninsured? Well, young adults, those 18 to 34, are disproportionately uninsured. Blacks, Hispanics, and other minorities such as Asians are more likely to be uninsured than white adults. For employment issues, even people who work full-time may still be uninsured, about 15% as you see here, and those who were part-time workers, almost 30% were uninsured. In general, we serve low-income individuals and populations, and they have some of the highest uninsured rates in the U.S. Here are additional resources that you can access after the webinar, and I will now go ahead and introduce our presenters today. First, we have Veronica Clark, who is the President and CEO of TCA Health. She became the CEO in May 2007, but previously served as the Chief Operating Officer. During Ms. Clark's tenure at TCA, she was responsible for agency operations, risk management, and personnel. She further has oversight for the organization's WIC program, Healthy Start, Earn Fair, Welfare to Work, and the Reach Out and Read Early Literacy program. We also have Ms. Marianne Chisholm-McGill, who is the Director of Programs at TCA Health. She has well over 20 years experience in working with community-based organizations to create, build, manage, sustain, and expand support programs for public housing and low-income families and individuals. Her role at TCA Health is to oversee WIC, Healthy Start, SNAP, the Health and Wellness Collaborative, and HRSA's Section 330 public housing grants. We're also joined by Dr. Laverne Barnes, who is the Medical Director at TCA. In 2007, Dr. Barnes opened Heal Thy People Family Care Center with the primary focus of providing patients with quality medical care as well as healing through community programming, educational seminars, and conferences that focused on physical, mental, and spiritual endeavors. Last but not least is Mr. Daryl Rogers, who is a full-time public housing outreach and enrollment worker and has been working with TCA for over 2 years and has served as a community health worker for over 7. He is primarily responsible for raising awareness of affordable insurance options and providing eligibility and enrollment assistance to uninsured patients of TCA Health Centers and public housing residents. I will go ahead and turn the presentation over to TCA.
Hello everyone, Ms. Veronica Clark, CEO of TCA Health Center, and I'd like to start today by giving a brief history of TCA Health Center. TCA Health Center was established in 1970 as a privately owned clinic, And in 1991, TCA Health began to receive federal funding and coverage to converted to an FQHC. Currently, the only FQHC in Chicago that is located in a public housing development. The clinic was developed to address the health needs of public housing residents. TCA Health is one of the first 7 FQHCs to receive public housing primary care funding. Our mission at TCA is to improve the health outcomes for the medically underserved community through the provision of high quality, affordable, and accessible health care and support services. We're committed to serving the needs of men, women, and children in all life cycles. We're also dedicated to empowering individuals and families by providing education that enhances and improves the quality of life. A little bit about our medical services. We provide family medicine services, pediatric, obstetrics and gynecology, optometric, dentistry, psychiatric services, pharmacy, and we also have an in-house lab. We offer preventive healthcare and ancillary services as well as TCA, and these include WIC and welfare work, support for pregnant women, childbirthing and parenting classes, breastfeeding counseling services. We do have immunization services, nutrition counseling, mental health services, licensed clinical social worker, in-house dietitian, case management, health education, and other enabling services. We also have wellness services, which includes youth sports fitness program, adult fitness program. We have a Cooking Matters class, community gardening projects, food accessibility initiative, community health, education workshops, registered dietitian, and we have now a new mobile medical van, which serves schools within the Oakville community and surrounding schools. TCA Health sites. TCA Health sits right adjacent to the Chicago's Oakville Gardens Murray home in the Riverdale community of Chicago on the city's far south side. And this is bordering Indiana, the state of Indiana. The community is isolated with very limited commercial and shopping areas, no public transportation. The area includes large tracts of land, sewer treatment plant, and a large forest reserve with open lands. The residential portion includes about 1,200 public housing families, which is surrounded by other low-income houses. The community is 96% African American, both young and I'd say, instead of saying both young, I'd say mainly young people. About 62% of the Oakville residents are under age 25. 78% of the Riverdale population lives below 200% of the poverty. Guideline and 56% lives below 100% of the poverty level. Health disparities affecting the community includes high rates of mortality, childhood obesity, asthma, diabetes, and cardiovascular diseases. The community is regarded as a food desert. The community is not without resources. There are also 6 public and charter schools, branches of Chicago Park District and Public Library, and TCA Health as a full-service federally qualified community health center. I'm going to turn this over to Mary McGill, our Director of Programs. She's going to go over the learning objectives of today's session.
Okay, good afternoon. Some of the teaching points for this afternoon, and we hope that you take away today, is to gain an understanding of TCA's best practices for outreach and managing the new enrollee for healthcare coverage. Hopefully you'll be able to take some of these ideas and share them in your own communities. Also to learn about creative outreach strategies to implement within your hard-to-reach communities. And also to share ideas that can strengthen the messaging about enrolling in healthcare coverage for the uninsured. We're going to go right into some of our planning stages and about some of the things that we did to guide the agency through helping residents gain knowledge about healthcare coverage. One thing that I want to tell you is that our guiding principles actually supported the new enrollees. The clinic took a very aggressive role in educating the clinic team by creating various informative work groups, and so Dr. Barnes will talk a little bit about that later in the presentation. A lot of these work groups we use to get the information out to our staff. We wanted to make sure that our staff was very knowledgeable about the uninsured population, so when people visit the clinic, they'll be able to talk more in detail about what was going on. We also provided resources and links to healthcare coverage so that our staff could actually stop into our computer lab and read about it, as well as some of our patients. We also took, the clinic focused on collaborating with our existing community partners. We began to serve as advocates in the community, making sure that the message was getting out to the uninsured about the healthcare coverage. And by doing this, we were able to educate a lot of people in the community, not just the residents, but also providers that were servicing at the various social service agencies. We also took the approach of being a good neighbor. Because we are strategically housed in the public housing community, we consider ourselves as a neighbor to the residents, to the public housing residents. Because we're housed here, what better way of servicing the residents by being a good neighbor? And we modeled this in everything that we did. So we used this as an opportunity to share information with the local laundromat, the grocery store, the library, the barbershops, the property management office, our waiting room in the clinic, the liquor store, and we did a host of enrollment and education activities. And finally, as a part of our guiding principles, is that we use this as an opportunity to identify ambassadors for the clinic. These folks were representatives of the community, but they also represented the clinic and were able to go out and speak in our behalf about the wonderful ACA opportunities that were available to the public housing residents. And we're proud to say that some of these ambassadors are actually some of our outreach staff and have become certified application counselors. And you'll see as Daryl talks a little bit about our activities, how some of our folks like the barbers, the community barber, are actually ambassadors for the clinic as well. And so I'm going to turn it over to myself. Sorry about that. But anyway, it's really important when new initiatives come on board that we identify what our challenges are, and being able to support the clinic going through the transition of servicing the public housing residents and getting them informed about the ACA. We had to identify what our real challenges were, but we also saw this as an opportunity as well for the clinic. And so, and I won't cover all, but I will share some of the ones that really stuck out at the clinic. One was that we knew that the public housing residents were engaged at the clinic, but they were only using the clinic for a medical emergency, so we needed to look at how can we address this. We also knew that our staff were not knowledgeable about everything that was going on with the ACA, so we needed to know that they were aware of this. We also knew that we had limited staff. We wanted to do this initiative, but at the time we were limited, so being able to get additional funding from HRSA to support this was a plus for us. Also, we knew that community residents were not educated about the ACA. We knew that there might be literacy issues or just people who were just not engaged in knowing anything about it. We also knew that because we are strategically sitting in a public housing community, that we would not be able to reach them where they were at, so we needed to strategize on that. We also were faced with the challenge of folks not trusting the system. They did not know whether we were part of Chicago Housing Authority or if we were part of property management, and so we had a lot of different challenges we were faced with. And then we also had the issue of the newly insured failing to use their benefits effectively. They were getting insured, but they were not using the services. And so we saw this as an opportunity. And so as you see our opportunities, some of them actually supported several different challenges. For example, we use this as an opportunity to socialize with public housing residents who we may not have been able to reach before. And so we use this as an opportunity. When you heard me talk about the principle of the good neighbor, this was a way that we did this. We actually went out and talked to them at every different venue that was going on in public housing. We also use this as an opportunity to educate the medical providers, the nurses, the MAs, and patient service staff about the expansion at ACA. It also allowed us to build a stronger team with the outreach folks. We actually went in and revised some of our selection and hiring processes to ensure that we had the best outreach team members on board. And we wanted them to be a good fit to be able to service the public housing residents. We also offered a host of opportunities for people to get education about the ACA, whether it was at patient services, whether it was they were talking to the doctor, whether they were just coming in and they wanted to do some research on their own. We had access for patients to use the computer lab. We also partnered with the Chicago Housing Authority to be able to do larger venues, because we knew that we needed to have more than just our outreach team talking about the ACA and about the services for the newly enrolled. And we also, this also provided the clinic with a response to those patients who were facing financial challenges. Those patients who came to the clinic or who stopped coming to the clinic because they did not have a medical card or they had no way of covering their health benefits. And so this actually provided an opportunity for us. And so I'm going to turn it over to Dr. Barnes, and she'll talk a little bit about building the bridge to the, for the newly insured.
Thank you, Miriam. You're welcome. As Miriam said, I'm Dr. Barnes, the medical director here at TCA Health. And what I want to talk about briefly is how do we actually build this relationship? How do we build a bridge to the patient that was coming in newly insured for the first time? And by doing this, we want to focus on three particular areas or three strategies that we used. The first one was our We Say Yes campaign. Now, I'm going to talk about just the three strategies briefly, and then I'll get specifically into that you see right on the screen. But in general, we focus on We Say Yes campaign. We focus on looking at the patients, and regardless of their financial or their insurance status, how do we get these patients into the clinic to provide them the care that they actually need? And then we look at, okay, after we say yes and provide them to come in, how do we continue to improve our process with them for patients coming in? There are different insurance that's going to be available through local agencies, through the Affordable Care Act, but how do we as a clinic capture these patients based on the insurance status where they were before they even joined the ACA? Then the third thing we looked at, which we'd like to talk about now, is the patient satisfaction committee. Because once we say yes, they come in the door, we provide an opportunity to improve their care, improve the numbers for them to come in. Then we want to make sure that the patients stay happy. How do we do that based on their insurance status and where they are? So we're going to start off just talking about the patient satisfaction committee. And the patient satisfaction committee, our vision and mission essentially is just to provide guidance on how to improve the patient and the family experience here in the clinic. Our purpose was to be a voice for the patients and to ensure that their point of view, their perspective, and their experience was not only heard, but that we integrated that information into our services and the quality that we provide to them. We want to make sure that we do this by focusing on patient-centered care. Through all of our services and their perspectives, we wanted those issues to be heard so that as they impact care, we actually can ensure that the next patient or family member experience is actually better. What this committee's responsibility included was an increased understanding of the new healthcare coverage system to support the patients, families, public housing community, and the staff. So we needed the patient to understand and staff to understand that the patients had a unique perspective on what the ACA was in general. We wanted to promote a respectful and effective partnership between the patients. the families and the staff. We wanted to strengthen our relationship in the community by supporting the residents' understanding of the Affordable Care Act. In addition to that, we wanted to display any new health care improvements or changes that have or will be made to support the needs within this community that we're serving. And then finally, we did want to serve as advocates, as ambassadors, as educators for these patients and families, and to show them that we're here in the community to serve their needs totally. How do we do this? We actually created a team called the Encounter Improvement Team. And that team was created essentially, initially to look at how we can, once we get the patients in, or how can we provide a service for the patients to come in where they would not feel intimidated or prohibit them from getting the care that they need. We wanted to take the fear of asking for an appointment out of the patient's vocabulary. We wanted them to be able to come in regardless of their financial status, regardless of what money that they may have. We had some past patients that actually had a fear of coming to the clinic because they had an outstanding bill. We wanted to take that information away. We wanted to look at the different insurance efforts that were offered. We had some local ones, but not only the state ones with Medicaid, but also county people. We actually found that even the people who were not qualified for county care actually were the ones we put on our list that eventually qualified for ACA. We wanted to focus on our external clients, the patients, all the outreach activities done within the clinic, not only for internal customers, but external as well. When we looked at any monthly health seminar topics that we were having, we focused as well on giving patients into the clinic who didn't have the ability to receive other places, like getting them to come in based on the actual health topic that was being provided for them. Then finally, we wanted to promote a commitment to certain patients. So we want the patients to be aware that we were committed, but also we wanted staff to realize we were committed. So we hosted a series of things within the clinics for each department that would promote them, letting patients know that they were welcome and that we wanted to serve them in this way. And finally, what really started it off was our We Say Yes campaign. We said yes to current, potential, and existing patients, definitely with some conditions of understanding. Again, we have those patients who cannot afford to come in, or we had a past outstanding balance. We wanted them to know that regardless of that, we still want to serve them. We were created here in this community, Urban Health Care Center, to provide their needs regardless of their race, creed, color, status, or financial condition. We wanted them to know that when we said yes, by saying yes, we have an actual vested interest in their care. We wanted to be their partner. We wanted to foster that cooperation relationship, and we wanted them to know that regardless of whatever they were mentally or emotionally, that we wanted to provide a care for them, as well as physically. And then we wanted to provide every opportunity for a patient to get the health care coverage. So we didn't want we chose to not turn anyone away. Anyone that came to our door, we wanted to service them. We looked at the insurance status that they had or that they didn't have, and we made a decision to become credentialed or to go after whatever insurance status that the patient had or whatever insurance coverage they had, and we applied for that insurance so that we could be their health care provider right in their community. And we wanted them to know that by doing that, we're going to reach everybody. We're going to reach the unreachable. Anybody that needs coverage or needs care, we're going to do whatever we need to do to become their provider of choice. Okay, now that we at the clinic have said yes, and we have our yes campaign, we needed to go back in and redefine outreach's effort to support the uninsured and the newly insured. And so one thing we had to do is before we went out to tell everybody yes, we needed to do some employee training with our outreach staff. So we began the process of conducting all staff meetings and providing training on the Affordable Care Act. You heard me talk about that earlier about we were doing this, but we were doing it in different ways. We were doing it in the huddles. We were actually going to departmental meetings.
We were doing individual meetings. We offered opportunities for folks to stop in and participate in workshops. We offered small workshops throughout the clinic. We held small weekly information sessions at the clinic. And in the sessions, what made it really unique is that we included both patients and community residents to sit in. So there were questions that patients were asking, that doctors or nurses were able to hear some of the concerns that they may have, as well as vice versa. Maybe a question that the doctor or nurse wanted to ask about the ACA. And so it provided a different type of atmosphere for our public housing residents to be exposed to. Then we did cross-training with all our patient service residents, so they all trained as county care assistants. We saw this as a benefit because when people came in, they were able to have those conversations about what was going on with the ACA, as well as what was going on with county care in the state of Illinois. We also use this as an opportunity to share information in the lobby. We also took it to heart when people shared their success stories. On any given day, we would have patients come in and ask for particular outreach people to say, hey, it works, I'm signed up. And so we use this as an opportunity to share those stories in our monthly news, in our quarterly newsletter, as well as at our staff meetings and doing clinic team huddles as well. And so it's giving those, sharing the good stories with the medical team so that they can see what we're doing with the public housing residents. Also, we knew what was key is that we needed to hire the right outreach staff. So it was an excellent opportunity when HRSA gave us additional money because now we can be selective. We needed to go out and find the key people who would be part of this outreach team that we wanted to revamp and redirect. And so we solicited recommendations from the community and with through Chicago Housing Authority. We sought someone who was a champion for coverage, someone who was interested. And a champion for us is someone, for example, who has not been insured since the age of 19 and now they're 31 and they're getting insurance for the first time. And so those who champion, they see that it's working, and so they will be able to go out and market the clinic and the ACA as well. We also sought someone who was respected by the public housing residents and the leaders in the community. We needed people who had a wonderful personality, someone who actually could service both young and the older population, someone who was flexible in scheduling because we needed people who could be on the grounds on Saturday and Sunday if need be to actually talk to public housing residents. We also needed someone who had a proven success record. I mean, I know we're looking for a hero, but we were looking for someone who actually was really someone who the community looked up to. We utilized the involvement of other outreach staff to participate. We never did this before, so outreach staff participated in our hiring process. They asked questions, some of the right questions that I might not know, or the CEO may not know, or the HR director. And so we also use this as an opportunity when we hired the person to do peer-to-peer training, because we know also that people tend to learn greater from people that are doing the job already. And so this was a different way for us, and so that was some of the ideas that we used with our selection process. Also, we needed to revamp the outreach team. So as I stated again, we received additional funding from HRSA. We also made sure that all of our staff were certified application counselors. We also made sure that they all were trained to do the Cook County as Cook County assisters. We also needed our staff to be manned up and educated about how to facilitate to larger and smaller groups, whether it was an individual. We wanted them to have as much information as they needed to know, whether it was about the clinic, whether it was about the ACA, but we did not want them to go out and be ill prepared. We also use this as an opportunity to do more than just work as the enrollment or the outreach person for healthcare. We needed them to do other things, and so, for example, we have one person on staff who actually serves as a mobile health van driver 2 days a week, and then they also do the enrollment services. We also needed our staff to be proficient about our clinic services, what they could be able to receive if they became patients at the clinic. We also gave our staff the opportunity or the freedom to schedule doctor's appointments. So that's a plus to have people out in public housing, because a lot of our residents do not have phone services. They don't have access to a cell phone. And so for us to be able to schedule appointments for them was a plus. We also use this as an opportunity to engage folks who had not seen doctors for a very long time, and so we waived fees for those folks that we knew up front that they were eligible to be insured. And so they were able to see providers, and they may not have seen doctors for years. And so this was an opportunity as part of our revamping. And so Daryl is going to come on board, and he's going to talk about some of the outreach strategies that they have really been creative at doing.
Good afternoon, everyone. Redefining our outreach strategies, we see that we have to attend small venues and large venues, which I like to call quality versus quantity. If you see at the bottom, it says all places that more than one will gather at any given time, because whether one person is there uninsured, they need to be covered, as well as if a greater crowd is gathered at the time, so you're looking for large numbers. In our small venues, we go to local advisory council meetings, and the reason we do that because these are the people that carry the information back to the residents. And we found that doing our outreach strategies that the best method is one person telling another person and encouraging them to come on and gain confidence. Also, our neighborhood grocery stores, you have moms, you have dads, you have children, you have uncles, you just have family members who always are going in there shopping because everyone has to eat, but everyone is not covered with health insurance at the time. All our initiatives that we held right here on site at the clinic, we participate in all different programs that go on because we are a full-service clinic that serves different populations. So we want to make sure that we address all needs, just not just the needs that they come in. We have those who come in at times who don't have insurance to come in for another program, but they leave out covered with insurance and an appointment at the clinic and haven't even been seen in years, as you heard earlier. We have our property management office because at the beginning of the month, every month, you have a large number of people who have to come through and they have to pay their rent in order to live where they are. So these are ways in which we are addressing those who maybe we want to catch on a daily basis coming through the clinic or either walking down the street. You have the barbershop in particular, which are focused on because you have plenty of people who work at the barbershop. They are not covered with insurance or they're not offered insurance. And many people will either overlook them at times, and then some do take advantage of the opportunity to get insurance. But you also have clients who are coming in the barbershop who are not even covered. You have a lot who are not even employed at the time. So that was our opportunity to reach out with the expanded Medicaid or the Medicaid for adults, which is known as the county care program for those who are unemployed and can't afford private health care. Liquor stores on Saturdays is a place that a lot of people would be intimidated to go to, either the environment or the crowd. But at the same time, we know that anyone going into the liquor store definitely needs health coverage. They're not to be overlooked because there are no smaller people and there are no greater people than others. You have the library where people come in. You have quiet settings. People coming to learn. That gives an opportunity to address people one-on-one and just see where they're at and see what they need for them and their families. You have high school lunchrooms. And the reason for this, because even though you have those who are not turned 18 or who have not turned 19 yet, they can either be prepared, they're either about to turn 19, they may be about to go off to college, or they can carry the information back home to their parents who don't have insurance, which leads me to the parent group. So then I don't really have to speak about that. Through various partnerships created, though, through the clinics and the wellness initiatives. And you heard earlier we spoke about our mobile health van that goes to the different schools through the clinics. I'm sorry, I apologize, you all. We have a mobile clinic that goes to the different schools to provide health care. But one of the things we have to do is get consent forms signed by all the parents of the children before they are able to visit. So during that opportunity, we are on site with our mobile laptops and printers where we can actually sign them up for health care while they are there at the same time getting health care for their child. So as I mentioned, all these places are more than one will gather at a time. We are looking to be there. Large venues, health fair, because it's a health fair and people are there for that specific reason to either get health coverage or to get services taken care of. Events hosted by the housing authority. It just helps build relationships with people who either don't trust. They see that you come out there, always live by the phrase, people don't care about how much you know until they know how much you care. So no one wants to come and get insured with you if you can't give them information and if you're not trying to tend to their needs. City colleges particularly, because I get a lot of questions from parents who have children off of school, and their question is, okay, what can I do for my child because they're not covered? What if they get sick while they're away at school? What if they have an emergency situation they can't get back home? So that is one of the reasons that we go out and try to get those covered at that time, because with the expanded Medicaid program, once again, with the county care, they're able to have emergency visits when they're away from home and they're not at their primary doctor at home with their parents. You have job fairs, because those who are unemployed, 9 times out of 10 can't afford to pay private health insurance premiums or fees during the month. So they become eligible for the expanded Medicaid program for adults. You have flea market, large crowds, walkathons, large crowds, community service fairs, large crowds, and community partner events. This helps build resources for referrals for those who are uninsured. And mainly when I look at churches, school events, and employee events, because everyone working is not always insured, and you never want to assume that people have something. As we go on to the next slide, these are just some of our outreach examples. You see our outreach workers are stationed in laundromats. You see we're stationed in libraries. You also see us in the LHC office, and you see us giving staff education. Main point about this slide is just showing that we meet the people where they are, but they cannot come to us. On this next sample, this is just an example of our marketing materials. When you see, now that you've got covered, we ask, what's the next step? Come ask us. One of the things we have found is that just because people get insured don't mean they have the information, or they then take their health insurance, or they take their health as serious. You see over there what we do, we send out a new member letter for those who have got approved and enrolled into the county care program, just to welcome them in. You even have those who may not have received their current identification card or their ID card yet for their health insurance, but we can call them and notify them that they have been approved, they have been enrolled, so at that moment they can come in and schedule an appointment with us here at the clinic. Ways that we service those who are newly insured. We provide them with information about how to utilize their health insurance. We find that most were more eager to get insured than to utilize their insurance. As you have some people that wait to the last minute, but they never see the purpose of getting preventive services before you get to that moment to where you have to be rushed to the emergency room and go to the hospital. We also see that our patient services staff, as was mentioned earlier, they are trained also in the clinic to assist the newly covered patients. And the reason is because it doesn't just stop with the outreach services. It becomes a community event. As they say, it takes a village to raise a family, and it takes a whole clinic to serve this person coming in for health care. On a monthly basis, we do review our county care portal, as I said, because we have those who are becoming new enrollees constantly during the month. This just gives us the opportunity to reach out to them to show how serious we are about their health coverage and their health care before they even have to reach out to us. And even going on through that, you have many people who have not had health coverage in 12, 20 years. You have so many years. I even had someone come in and tell me that this is the first time they've had health coverage their whole life. So when you think about that, this is someone who's had to go to the emergency room constantly for their whole life. And most of the time probably couldn't even pay their health care bills. Our newly covered, they also didn't understand the purpose of preventive screenings, as we said earlier. So that's why we have staff on hand. We have medical directors, we have clinical staff. So it's not just an outreach opportunity. Once we bring them in, we have staff that is around them who can give this information, who can make sure that they are seeing they are taking care of those health needs that they do on a daily basis. And lobby education for those who are just waiting on an appointment. So as time goes by, we just see that as an opportunity to give them information about their health care. And at that moment, you may have the opportunity to find out about someone who is not insured, and at that moment, they can get enrolled into insurance. We secure our daily appointment books, and on our daily rosters are shown with self-pay, sliding scales, and those who are uninsured. The reason we find this, I apologize, you all. The reason that we look at that list on a daily basis is because when we see that they're coming in at a certain point in time, what we try to do is reach out to them and get them in here a little earlier before their appointment. That way, if they're not registered with insurance, we can get them enrolled into a plan in the program so that maybe they can then get seen that day. And not only will they get seen that day, their appointment here at the clinic will be waived because of the time that they spent to come in for a few minutes earlier to enroll into health care. So as we go on to the next slide, these are just a few success stories that we have seen and that people have expressed to us after becoming enrolled. And one of the ones that stand out to me was the one mentioned at the beginning, was the independent barber, Andre, who went 8 years without having health insurance. And the funniest thing was he was resistant at first about getting his health insurance, and it took him a while to get his information in and get covered. But the time that he received his health insurance card and came here to the clinic, he went around the whole clinic telling everybody. He came to find the outreach staff that enrolled him, the person who referred him, and he walked out the door so excited. So it just tells us that even when people act like they don't want health care, it really does mean more to them than they give off, and it just shows the effort that we have to keep reaching out to those who are uninsured, because they will benefit in the end. And as you just look through the slides, you can see that we have other various stories of success of those who enroll into health coverage. So at this time, I will turn it back over to Mary McGill for the closing remarks and the takeaways for best practice.
As Daryl shared, some of the takeaways that we want you to walk away with and really understand, for us, we recognize at TCA Health that the outreach staff play a very important role in educating the uninsured about health services and benefits. We also recognize that all staff members, the entire medical staff and the support staff, serve as advocates to ensure that patients understand their benefits and actually understand how to navigate through the system. Because when they come in, they're like kids coming into the classroom for the first day of school, and a lot of patients that come in are very lost about what they're entitled to and how to use this. So having your staff be on board is very important. We also use this as a way to create the principles or the guidelines that we would live by as a clinic, because we recognize that people that were coming through the doors, that their lives were going to be changed because of the ACA, but we also knew that we needed to make changes as well as we do business at the clinic. We also recognized that it was important to spend time talking with people about preventive care when they are being enrolled. It's part of educating them on self-care. We also recognized that we had to be prepared to meet people where they were at. So that meant when people came in our door, sometimes they didn't go straight to patient services. They came to outreach to sign up for health care. And a lot of people that we met on those days, and we meet even today, they come in and they're sick. Or they've been open, they're not feeling well, but they don't want to go to patient services because they don't have any coverage. And so we take the time to pull people from the medical team to come in and talk to people. For example, we use a health educator. We have someone that comes in, and you will have people that come in and say, you know, I was diagnosed with high blood pressure when I was 19, but you're sitting there and you're looking at somebody who's 27, but they haven't had any medication since then. So we use the opportunity to have medical staff come in because they play a very intricate role in being available to talk to people about some of the health issues or concerns that they have. And so these were some of our takeaways, and we hope that you take away some of the lessons that we learned and some of the practices that we use at the clinic. Thank you for participating. If there's any questions?
So I would just like to thank TCA for joining us today for the webinar. Thank you for all the information that you guys shared about strategies to reach these special populations and the underserved, as well as managing those that now have insurance, are now presenting at your health center. So there's a lot of information for health centers. While I'm waiting for people to start asking questions, I have a few announcements. So if you would like to ask a question, just type it into the box that's located in your control panel, and I'll go ahead and forward those questions over to TCA. As a reminder, please visit our website, nchph.org. It's newly designed. We just released it early this week, so check it out. And also, this is the location where you can view archived webinars, provider and resident-centered fact sheets, and brochures and information. So just check it out to get more information about open enrollment, services, managing new enrollees, and all of that. Also join our mailing list to receive HRSA updates, resources, and information about funding opportunities. And also consider following us on Twitter at NCHPHORG. And for the upcoming symposium that we're having, we already have our hashtag #PHPC 2014. So if you will be attending, don't forget to use that hashtag when you're tweeting. And that brings me to the upcoming symposium. where we are having a spring break special registration discount to those who are paying the full registration price. It's 20% off starting April 18th through the 21st for those 4 days of spring break. So just check that out at our website and also at our registration site for more information. And we ask that health centers and individuals that are staff at health centers nominate their organization or an exemplary individual for the 4th annual H. Jack Geiger Award. So you can receive more information about that at our website. And then, of course, feel free to contact any of us at the National Center for Health and Public Housing for more information about upcoming events, webinars, resources, our mailing list, or how to get in contact with TCA. So I'll go ahead and open up the Q&A portion. When you were out in the community, what other kinds of, or how did you address the needs and reach like other minorities other than blacks, like the Hispanic population or any other groups?
Mary Ann McGill responding. I want to say that one of the things, if you look at the stats in the community, even though we're in public housing, there's probably about 96% African Americans, so there are other nationalities in the housing development. And our service area does service other populations, but we primarily focus on public housing. Mm-hmm. And that's our hardest population. And we also service Hedwig community, which is a community that's adjacent to our community. And so in that community, we have other, it's mostly, primarily Spanish-speaking population.
Mm-hmm. Okay. And did you have to translate any resources, or
Yes.
How did you design some of your resources?
Yes, we did. As a matter of fact, through our mobile health van, we just partnered with a school in Hedwig, and one of the things that they asked for was that we translate our materials to Spanish-speaking population. What we did was we were able to do that. We did that through CPS, and we also have staff on in our patient services.
Oh, excellent. Good. And for the training,
I'm sorry, we have providers on staff that speak Spanish as well.
Okay. Yeah, that was another question about training. Was the staff all required to be bilingual, or you had just a certain amount of staff that were bilingual?
Yeah, our staff are not required to be bilingual. I think that's a plus. But we do look at the community that we serve, and if there is a need, we tend to look to it to try to accommodate. But for our purposes, for what we do, especially with Hedwig, with our mobile van program, we will, send the appropriate provider in that area to be able to accommodate those patients.
Okay, great. And overall, how many people did you hire during that initial phase of open enrollment?
Open enrollment, we actually have a team of 4 outreach staff.
Okay.
We brought 2 new staff on board, and both were public housing residents.
Oh, good. And
Same thing we said.
Okay. And did you receive any additional funding beyond the HRSA outreach and enrollment funds?
No, we did not.
Okay.
But we're welcome to receive it.
Okay. So did you also accept any volunteerism or assistance from the local community? So you listed those venues, but did any of those organizations participate as volunteers for enrolling people?
Yes, yes. And I have to say, we worked with Chicago Housing Authority. We worked with the LAC through a special grant through, and UCAN. Those were 2 of our partners. But several months ago, probably about 6 months ago, we partnered with the Chicago Housing Authority. Although we had a relationship, that was an opportunity for us to sit with them on a larger scale to identify how could we do numbers in a large, to really get the information out to public housing residents. And so Heartland Alliance had a small grant, and they actually came to Chicago Housing Authority along with several other FQHCs, and we talked about how could we do things on a larger scale. So Heartland Alliance partners with us, and so when we have big events, we know that our team of 4 people cannot do all those enrollments. So we invite other agencies to come in to gather those numbers for us. I think the great thing is that we've moved away from trying to do it all by ourselves, and so we partner with some really dynamic partners that come in. So for example, for the month of January, February, and March, we work with the LAC, our local advisory council, who's in public housing. She's kind of like, I don't want to say the leader, but she's the kind of voice for the community. And she hosted several events, and we actually were the enrollment staff on board, but we invited another provider to come in to help with the enrollment. And so we definitely joined forces with other agencies.
Oh yeah, that's great. And what is the LAC office?
Local Advisory Council.
Okay.
And then there's another. And they actually report to the Chicago Housing Authority. So there's a leader in each housing development in Chicago who reports to. They report to the CAC, which is the CAC represents the. I'm trying to think of the word. I don't want to give you the wrong word, but what I can do is I can give it to you at a later. I can send it to you, and you can share it with the group.
Mrs. Ryan,
okay.
What I wanted to say a little bit more about LAC for listeners is that they represent the community, the residents of the community. They're the voice of the residents. That's pretty much who they are.
Yes.
Okay. And another question, just a general one. You may have mentioned this, but what does TCA stand for?
TCA originally is the clinic in Oakville. When we first started in 1970, when we were founded, it was Oakville Health Center. Then it was changed to the clinic in Oakville. And then afterwards, we've had changes on the board, changes in leadership. So the name, we had a name change to back in 2003 to TCA Health, otherwise known as the clinic in Oakville.
Oh, okay, cool. And how do you access the county list of newly enrolled?
Daryl, you want to speak on that?
We're going to the County Care Provider Portal, and which is produced on the 21st of each month for those who are now became newly enrolled during that month. And at that time, we're able to do a comparison on patients who have either already scheduled appointments and come into the clinic, and we can identify those who are enrolled but haven't made an appointment or haven't been to the doctor. So at that time, we just print the list out and we do a comparison, and then we call them and try to get them to come in and schedule appointments for preventive services as soon as possible.
Good. Very good. Our next question is, how did TCA reassess the uninsured patients in their clinic, and also what is a pink card patient?
Good question. A pink card patient is a Medicaid card or Illinois assistance card for a woman, for a female. And so we call it the pink card. So they're able to access gynecological services and have a primary provider that is an OB-GYN or obstetrician or gynecologist. And what was the other part of the question? How do we
reassess the uninsured patients in the clinic?
You mean that as far as their clinical status? How do we reassess them? What we tend to do is pull our empanelment list, and our empanelment list looks at those who are self-pay, those who are insured. We look at them based on the last visit, whether or not it's been 3, 6, 9, or 12 months. We actually have a roster patient who's not been seen in 2 years, and we look at the patients overall and try to get them in for natural visits.
And I want to add also something that we do with outreach is outreach meets with patient services every morning to see who is scheduled for an appointment, and we are able to see who has insurance and who does not have insurance, and those are the folks that we kind of I don't want to say tackle, but we actually target them in the waiting area. So when they come in, we talk to them about getting insurance.
And when you were out in the community, how many people just said that they would rather just take the penalty for not enrolling? Or do you have any statistics on how successful your efforts were?
You always run into some who are a little skeptical, and they inquire about just taking the penalty, but that's the side where the education comes in and talking to the patient and telling them the importance of the preventive services, because a lot of people, they either don't want to pay for health insurance, but they don't understand the importance of having it. So once you begin to talk to them about the purpose of their health, purpose of getting screenings, whether it's getting blood pressure screenings, whether cholesterol, those various things, diabetes, that can affect their life longer down the line. You talk to them about wanting to be here for their children. You just have to talk to them heart to heart and take the number off of them as someone you're just trying to get insured. And I found that most of the time, 9.9 times out of 10, that person decides to get insurance when at first they were about to walk out the door. You have some who just walk away, and I've had some who walked away and came back 3 months later and still got enrolled. So you just have to really meet them where they're at. You can't walk away from them just because they say, hey, I'd rather take the penalty. You have to take it more serious than them sometimes.
Yeah. And speaking of that and continuing with the newly enrolled, do you have patient navigators or care managers or organization?
We do not have patient navigators.
Okay. So is it just incumbent upon the staff that you do have to make sure people are understanding how to navigate the health system, and how do you handle like additional services?
We are presently in the process of becoming a patient-centered medical home, and within that model, care coordination or care management. We're in the beginning stages of that, and we're just rolling that out. And we've been doing probably the last 2 months trying to bring the staff up to par on the training. We do roll out our care managers and care coordination actually in May. So those particular individuals, as part of that care team, is responsible essentially for navigating patients through the healthcare system, whether or not they're getting the proper referrals, lab requests, the appointments, actually following up for care, looking at their whole health system quality-wise to make sure that they get what they need. When we started the ACA process, we didn't have that. It was on the horizon, but it had not been brought to fruition yet. So we're in the very infantile stages of that. And so probably a year from now, when we ask us that question, we'll probably have a lot more information for it.
Yeah. And now that open enrollment has closed, what other outreach efforts, or what are you still doing for the outreach and enrollment?
Just at this present time, we are still educating those who have received insurance because that is what's required of us at this moment. So we do keep continual education. We're still trying to schedule at different locations with events and things going on. And even though the open enrollment is closed, people can still enroll into the county care program, which is the expanded adult Medicaid. And you still have a special enrollment period for those who weren't able to get successfully enrolled during that time if they had special circumstances or had any situation that prevented them from being able to enroll at that time. So we still educate them about health insurance and the reason for it and the importance of having it. So it doesn't stop at this point.
And I want to say that we also are looking at some additional deliverables, because we're looking at those enrolled who have been denied coverage. So we're working with them to address appeals. We're looking at those who have exemptions. And so there's a host of other activities that we're doing to support the public housing residents and the newly insured and those who are not insured yet. And I want to say also another campaign that we're doing is Ask Us What's Next, because we have people, as we stated before, who are on our roster who have been covered and still have not seen a doctor. So it's more so, we have several campaigns that are going on at the clinic. We want them not to sit at home and only use their health care coverage for emergencies. So it's like, what's next? So there's a lot of stuff that we're doing outside of just enroll them.
Okay. Okay. And the last question, and it's back to the list of newly enrolled. Someone said, can you speak a little bit more about that? How do you get the overall list of newly enrolled?
For county care, we're able to go into the system every month and pull down the list of people who are enrolled under county care.
Mm-hmm.
But for ACA, we're not able to do that. You know, we're not able to look at that. But for county care, we're able to do that.
Okay.
And when we pull that list,
different for different areas, possibly.
we can't hear you. I'm sorry.
It's a little static.
Oh, I said it may be different for different areas. So if not everybody has, as you said, county care, because that's specific to Chicago, maybe in their area they may have to contact another entity to receive a similar list in their area.
Exactly. Because we're able to go on the system. We don't have to go through anyone. We can go on the system and pull our own list down. We can see who has been assigned to for coverage.
Yeah.
And that list includes who's pending approval, and those who are considered members and already have been insured.
Oh, okay. So it's a very comprehensive list that you have access to. Okay, excellent. So I would just like to remind everyone that the session was recorded and that the slides, resources, and PowerPoint will be made available to you after today's webinar and will also be posted to our website probably after next Monday. So check back on our website for more information. You'll have access to the slides. Also, I would just like to thank you guys once again for scheduling this time to educate and continue providing information about the outreach efforts in low-income communities, specifically at PHPCs. So thank you to everyone who attended today's webinar, and have a good day.